Welcome to Medical Logistics 101. Heartburn, red flags you should not ignore. GERD Overview. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Definitions. Heartburn is a burning discomfort behind the sternum caused by acid reflux. GERD, or gastroesophageal reflux disease, is a chronic or recurring reflux causing symptoms or complications. It's caused by lower esophageal sphincter dysfunction, transient relaxations, or increased abdominal pressure. Causes, risk factors: large meals, late night eating, obesity, pregnancy, hiatal hernia, caffeine, alcohol, chocolate, or peppermint, non-steroidal anti-inflammatory drugs or NSAIDs, smoking, acidic or spicy foods, lying down after meals. Signs and symptoms: burning chest pain after meals, regurgitation of sour or bitter fluid, symptoms worse when lying down, chronic cough, that's a big one, hoarseness, throat clearing, a sensation of a lump in the throat, also known as globus. Physical exam. Most patients have a normal exam. Possible findings: mild epigastric tenderness on palpation, pharyngeal irritation from reflux, and sometimes dental enamel erosion in chronic cases. Diagnostic studies: really you want to exclude other causes of chest discomfort, especially cardiac. Testing for GERD is recommended when symptoms are persistent or atypical. Gold standard is EGD or endoscopy. The gold standard for looking for chronic cases where you have difficulty swallowing, dysphagia, anemia, weight loss, GI bleeding, long-standing symptoms. Any of these really require an EGD. Other diagnostic studies that are sometimes done: pH monitoring if the diagnosis is unclear, esophageal manometry if there's a motility disorder of the esophagus suspected, and H. pylori testing if dyspepsia also overlaps. H. pylori is a chronic infection of the stomach lining that can cause certainly gastritis, as well as increase the risk for gastric cancer. Differential mimics: peptic ulcer disease, esophageal spasm, biliary colic or gallbladder disease, gastritis, cardiac ischemia. I always get an EKG on these patients. Esophageal strictures, and a rare condition called achalasia, where you have a chronic disorder of esophageal motility. Red flags: dysphagia or difficulty swallowing, odonophagia, painful swallowing, unintentional weight loss, vomiting blood or black stools, chest pain, symptoms not improving with treatment, age greater than 50 with new symptoms. Complications: esophageal strictures, where you have a progressive dysphagia or difficulty swallowing, Barrett's esophagus, which is a premalignant change at the junction of the esophagus and the stomach, and esophageal adenocarcinoma, a rare but serious condition which unfortunately may not produce symptoms until it's pretty far advanced, so it's important to catch it early. Chronic cough or laryngitis is sometimes seen with this, as well as dental erosion. Pitfalls: assuming chest pain is just reflux. I always want to rule out other causes of chest pain in these patients, particularly cardiac causes. Missing dysphagia or odonophagia, overlooking nighttime symptoms, not recognizing chronic cough as reflux related. That's a big one. See that a lot. Underestimating long-term risk. Barrett's esophagus, as I said, it's a premalignant change that significantly increases the risk for esophageal adenocarcinoma, and unfortunately may not produce much in the way of symptoms. That's why the EGD is so important, because it catches it early. Disposition: outpatient, usually for typical symptoms. Diet and lifestyle changes, antacids such as Tums, H2 blockers such as famotidine, also known as Pepcid, and proton pump inhibitors like Prilosec and Nexium. Disposition: urgent evaluation for GI bleeding, severe chest pain, persistent vomiting, inability to swallow fluids, think strictures or esophageal obstruction. These patients will oftentimes have a known history of chronic reflux and may even have a known history of esophageal strictures. They've eaten like a piece of steak or chicken, and they can't pass it beyond that esophageal sphincter into their stomach, and usually these patients are not able to swallow fluids, may not even be able to swallow oral secretions, and that's going to obviously be an admission for an EGD to clear that obstruction. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.